Okay, what is the most likely cause for this patient's laboratory findings? Alcoholic ketoacidosis, diuretic, antacid, renal tubular acidosis, or salicylate toxicity. So 50-year-old man with a history of GERD presents to the clinic with complaints of persistent heartburn. He reports using over-the-counter antacids multiple times a day for the past 3 weeks. Laboratory results show serum bicarb of 34, blood pH of 7.47, and a normal anion gap. What is the most likely cause? So he has a metabolic alkalosis.
Okay.
So I'm gonna rule out all the acidosis ones. So ketoacidosis, tubular acidosis, salicylate. So is it caused by the excessive antacid use or diuretic use? So I know diuretics, yeah, you can cause metabolic alkalosis, I'm pretty sure, because of volume depletion and then activation of the renin-angiotensin-aldosterone system. And then I don't know if excessive antacid use causes alkalosis. I mean, you're blocking excretion of an acid. I don't know, even the question points to like excessive antacid use. I can't think of a mechanism how that causes an alkalosis, so I'll go with the diuretic.
Okay. So talk to me kind of what is in an antacid?
Like a PPI, oh, like PPI blocker is what I was thinking. But I
What
guess it
what
could be,
what other antacids are there out there? I
oh
mean,
yeah, you can give calcium carbonate, which would cause, yeah. I was just thinking PPIs.
okay. What do you want to do?
Okay, yeah. It's the excessive antacid use, yeah.
Okay, so I want you to kind of think more in these cases, think more clinical, right? So
Yeah.
I always think about cause and effect. If they're telling you that they're taking multiple drugs, whatever that drug is, right? If they're taking multiple laxative, multiple antacids, multiple something that, and then all of a sudden they say like, oh, the labs then turned to this, or then they started having problems. To me, I want you to think of cause and effect. Most likely it's because of that drug use. You know what I'm trying to say?
Yeah.
So think of it clinically, because I always say, like, if a patient came to you and go, hey, I don't feel too good, but I've been like taking a bunch of antacids every day, and then you do it, run labs, and the labs are all over the place, you're not going to be like, oh, it's probably something weird, right? You're going to be like, oh, it's probably all the antacids you take. You know what I'm trying to say?
Yeah.
On a logic clinical standpoint. So yeah, so like for instance, Tums, calcium carbonate, and things like that, right? If you take a lot of it, that's practically just like, you know, um, calcium with bicarb, right? So you're overloading your system with bicarb. So then of course you're gonna have alkalosis. So
I know I was so fixated on PPIs. I was like, PPIs do not cause alkalosis.
yeah. So just, like I said, think, don't tunnel vision too much for yourself, right? Think about, oh, what kind of antacids are there, right? There's multiple, right? There's way more than just PPIs, right? PPIs are the strongest antacids, I would say, but over the counter Pepcid, right? Famotidine is a antacid, right? Tums is a antacid. So there's multiple antacids. So